the goal of this overall program is to increase diagnosis and use of mental health services. So we definitely saw evidence that that was successful.
Welcome to Talking About Kids. I'm your host, R. Bradley Snyder, researcher, activist, and author of The 5 Simple Truths of Raising Kids. As I'm sure you are aware, the U.S. is in the middle of what many experts are calling a mental health crisis. As a result, there is increased interest in initiatives that place mental health clinicians on campuses. Despite research suggesting that this model should help students, there was, until recently, little evidence that school-based mental health services have the desired impacts. My guest this episode is Ezra Golberstein, Associate Professor of Health Policy and Management at the University of Minnesota School of Public Health. Ezra and his colleagues recently published an article entitled Effects of School-Based Mental Health Services on Youth Outcome, in which they examined the causal effects of the approach. He and I discussed those findings here. This episode is sponsored in part by the Arizona Department of Health Services Must Stop Bullying campaign through its Title V Maternal and Child Health Program. For more information, go to muststopbullying.org. Talking About Kids is designed to help parents, teachers, and other professionals help kids. If you enjoy it or you enjoy this episode, please consider giving it a positive review and sharing it with your friends and colleagues. Go ahead. I'll wait. And now, the interview.
A major area of my research interest for a long time has been mental health services and policy. And as part of that, one of the really interesting and important things about mental health and mental illness is that it affects what economists refer to as human capital in a really big way. And by human capital, that basically just means like people's capabilities that allow them to do all sorts of things in life, whether it is in terms of their work or their profession or their more social aspects of their lives. Think of it as just like broadly stated human capacity. And the reason why this is such a big deal for mental health and mental illness is the epidemiology of mental illness, which is that in contrast to most other types of diseases or health conditions, mental illness usually strikes earlier in life. The best and most frequently cited epidemiological evidence on this suggests that 3/4 of mental disorders have their first occurrence before age 24. Um, and why is that so important here? It's really important because that means that mental illness is first striking and frequently striking when people are in this really critical phase of their development, when they are accumulating their human capital, they're building skills, and like in that sort of like an economics language and like everyday language, that's when people are in school, they
Right.
are developing their cognitive skills through education along with non-cognitive skills as well, both through education and all parts of their lives. So the implication of that is when mental illness disrupts people's educational processes and attainment, that's not something that matters just for that moment. That's something that has potentially lifelong implications. And as an economist, that's a really fascinating thing that makes this really important to study because it means that investments
Mm.
that we are trying to make to encourage overall well-being, which also includes this idea of human capital and human capacity, needs to be taking into account mental health at young ages, and we have to, when we're considering, the costs and benefits of different types of investments, we need to be thinking about things like if we can do a better job of tackling mental health in childhood, how is that affecting all other sorts of things that maybe are academic related, for instance? Um, so I got interested in that question a long time ago. I did one research project that we published, I think, almost a decade ago now, that was looking at what happened when, because of the FDA's black box warnings for on pediatric antidepressants
Mm,
in the, around like 2003, 2004, um, that created an interesting natural experiment because it led to a really sharp decrease in the rate with which adolescents were using antidepressants.
right,
And so as an economist, another thing about us as a profession is that we're obsessed with really, really high quality evidence in a world where it's oftentimes hard to really know definitively did something work
right.
or not. Um, and that was what we call like this neat natural experiment. There was a sudden change in antidepressant use, and we realized, oh, we can leverage that change to learn something about how does treatment for depression in adolescents affect human capital related outcomes. And sure enough, we found right as adolescents were less likely to use antidepressants because of the FDA's black box warnings, there was also a worsening of academic outcomes,
Mm,
suggesting that this mental health treatment is doing something really important for adolescents in terms of their human capital outcomes. Um, After that work, I just was sort of remained interested in these sorts of questions about how does treating mental illness or diagnosing and treating mental illness in youth affect a range of outcomes. And so I work at the University of Minnesota. I'm a professor there, and a while ago I had read a news article about how the state of Minnesota was creating this grant program to fund school-based mental health services across the state. And that piqued my interest as just because that's
right.
for all the reasons I just described. And so I dug into this a little bit and realized, oh, this is a really neat program. It's funding a particular model of school-based mental health services, which is taking licensed mental health clinicians and just placing them directly in K through 12 school settings where they do the work that clinicians do of diagnosing and treating mental illness, not prescribing drugs, but
Right.
counseling and therapy sorts of work. And maybe in some ways, what was even more interesting for me was the way that this was implemented in the state of Minnesota, which is that this grant program started in like 2007, and then it just gradually expanded because every Minnesota is a 2-year budgeting process at the state legislature, and every 2 years, the budget for this program got bigger and bigger and bigger, which meant it got expanded to more and
Right.
more and more schools across the state. And sort of like what I learned about that FDA black box warning, sort of the light bulb goes off over my head, like, oh, here's another neat natural experiment that we can look at to try to learn something about what is the effect of putting these mental health services directly in school settings. Um, so that was and so that there was that idea, and then we realized we had access to some really, again, this is just sort of academic talk, but really cool data.
Right.
We were able to access linked administrative data from the state of Minnesota, which allowed us to link together information on schools for kids, so we know which school each kid went to
Okay.
in each year from going all the way back to the year 2001 through 2019. Um, and we were able to link that with information on what happened in the school. So things like attendance,
Mm,
standardized test scores, disciplinary actions. We were able to link that with administrative Medicaid data for the kids that received their health insurance from the Medicaid program
oh,
in
wow.
Minnesota, which is Medicaid is the largest single insurer of kids in the country, and that's true in our setting as well. So we were able. That means we had information on what sorts of mental health services kids were actually
Right.
using. So we were able to link that together with the school data. We were able to link juvenile justice data as well. So we knew if kids in each year had any involvement with the juvenile justice system, and we were able to link that with information on child welfare data, because we know that any involvement with the
Hmm.
child welfare system is this huge tracer flag
Right.
for all sorts of current and subsequent mental health problems. So we think that that could identify particularly high risk kids. Um, and we also found this other data set altogether called the Minnesota Student Survey, which is a huge survey that's done every 3 years by the state of Minnesota. It's by the Department of
Hmm.
Education and the Department of Human Services. And what was important for us there is we were able to pull together 7 different waves of this survey over this 19-year period of time And in those 7 different surveys, they asked consistent questions around suicidality, both whether kids reported having attempted suicide in the past year or having suicidal ideation, just thinking about suicide in the past year, and also some questions about the use of different types of substances in the past 30 days. And so we had that information we were able to get. Then we went out, our research team went out, and we collected information for every single K through 12 public school in Hennepin County, Minnesota, between 2001 and 2019, whether they implemented this school-based mental health program that was funded by the state, and if so, did they do it, and if so, when? We limited ourselves to Hennepin County, which is the largest county in the state. It's where the city of Minneapolis is. It's a mix of urban and suburban areas,
Okay.
just because it was really hard to collect all that information, and we had to set some limits in what we were doing. But Hennepin County is really big, and so we had information on over 250 schools in that period. So we were able to just trace out when schools actually implemented this, and then link that with our other rich data sets on student outcomes. I just talked a lot, so I'm going to pause
No,
now.
so
Yeah.
I'm taking all that in, and I actually think that the regular listeners of the podcast are going to be familiar with the Minnesota Youth Survey because it's something that's come up before. It's actually one of the
Mm.
first surveys that asked students about their adverse childhood experiences. That was really early
Oh, yeah.
on. I think it was the first actually that asked directly of students because otherwise it had been assessed through their parents. So, yeah,
That's very interesting. Yeah, so I hadn't realized that. This was, yeah, the Minnesota Student Survey was actually totally new to me,
yeah.
and we sort of happened on it by accident, because it's not something that people in my field of economics had. It's not something that just I had ever encountered before. But when we did, we were really delighted that this resource existed. It has incredibly rich information. It's a huge survey,
Right.
actually.
Well, and
Yeah.
so one of the things that I wanted to know is like, thank you for providing the definition of school based mental health services, because there are a bunch of different models out there.
There are, yes, and we were looking at one model in
Right.
particular, which is not to say that it speaks to all the different models, but yes.
Because one of the models too is so there's a co-location model where there is a community-based provider that kind of sets up shop within the school or adjacent to the school, and then there's a more of a referral model where there's somebody on staff that can do a handoff to a community-based provider. But this is having licensed mental health providers in the school. Now, what did they have? Do you know what they had prior to that?
Yeah, so that's obviously important context for even interpreting what we found in our
Right.
study. So it varied a bit from school to school, but but schools didn't have much in the way of any sort of
Mm,
clinicians. So schools had differing amounts of what I think are sort of standard student support
right.
services, by which I mean school counselors, school social workers. And again, that varied a bit by school to school, but all schools had at least something. Those are people who are employed directly by the school districts. Um, and um, I My understanding is that, yeah, some of what those professionals delivered you might consider
Mm,
mental health counseling or therapy, but typically not in the way that we think of as being services that are
right.
delivered by a mental health clinician per se.
Right.
And yeah, for many of those professionals, that their job is not, it's just not doing therapy or mental health counseling. It's just doing more sort of general counseling and support for students. So there were maybe a few schools that had some limited resources that were explicitly mental health, but it wasn't that much for the most part.
Well, and I think also important for the listeners to understand is, I mean, obviously, since the beginning of schools, we've had teachers that acted as informal counselors that play a really important role, and other staff as well. But as we know, that kind of role is hard to replicate. So it's hard to say, oh, we have this person that the kids really like to talk to. That's hard to turn into a program where you can have an impact on a population, for example. So doing something
Yeah.
like this is something that you can say if it works or if it doesn't, or how well it works and for whom is something that you can roll out to other places, right?
Yeah, absolutely, and that's a big part of it as we got into this. Um, so when I started this project, I was very naive
Mm.
about just how big the school mental health world is. And as I will speak self-deprecatingly about my profession of economics.
Right.
We frequently will move into an area and not totally understand everything that has been going on or the work that people have been doing for decades in the case of school mental health. Um, so I learned a lot, and one thing that was really important is one of my co-authors on this project, Mark Sander, is a school mental health person and has been working explicitly in school
Mm.
mental health for decades, and was just critically important with and also has been involved in directing the Minnesota the Hennepin County and Minneapolis Public Schools school-based mental health program. So I've learned a tremendous amount about it from him, and that's been really really wonderful and important for this work.
Well, I mean, I don't want to belabor this point, but I mean, the entire discipline of education has been plagued by an inability to replicate things, right? This is we and it's often talked about as it's hard to replicate that great teacher. Like it's hard to like whatever that is going on there in that relationship, but it flows through the programs throughout the school. I mean, and then it's even the case that we have trouble within a district getting all of the schools in that district to have the same kind of success or to see the same sorts of things in their students. So whenever we have an opportunity to look at a program that seems relatively uniform, we learn a lot. And what did you start to learn? So what was I mean, because I think we know what the promise is. You kind of went over that in the introduction. The promise is that if we can address these mental health issues early, that we have healthier, happier, more successful students with better outcomes economically, education, academically, less involvement in the criminal justice system, all these things that that some of the listeners know get captured in. I'm going to pull out some economics terms since I'm talking to an economist here. All these things that try to get captured in the Heckman equation that we're all fond
Oh,
of.
yes.
So, yeah, and so what were your findings?
Yeah, so the initial caveat is, we were able to look at the things that we had information on, which
Right.
is certainly not everything that is important, but we were able to do a lot. So we found some, and I'll say, we found some things that I think are super encouraging, and where I would also characterize our evidence as being pretty robust. Found some things that are encouraging, where the evidence was a little bit weaker, and then we found some things where they're just we didn't find anything. So
Okay.
I'll go in order there. We found what I would characterize as very strong evidence that for kids that were receiving their health insurance from Medicaid, for whom we could actually say something about their use of mental health services because we had the data on it for them, um, we saw an increase in the use of any mental health services, about 7.6% compared to where they were originally, not percentage
Okay.
points, but percent, which is still it's a meaningful increase. That was driven nearly entirely by the increase of psychotherapy use. We saw a
Mm.
13% relative increase in the use of any psychotherapy among kids in schools after schools implemented this program compared to before it and compared to schools that did not implement this program. So and that's in some ways maybe like, that's the first order. The goal of this overall program is to increase diagnosis and use of mental health
Yes.
services. So we definitely saw evidence that that was successful. Um, and then we found also, I would say the other more really robust piece of evidence, which is incredibly important, is that using the data from the Minnesota Student Survey, we found that after schools implemented school-based mental health services, there was a statistically significant and actually I would say pretty meaningful in terms of its magnitude reduction in the likelihood that students reported attempting suicide in the
Mm.
past 12 months. Um, and that reduction was around 15 percent compared to the average level. Unfortunately, you know, the vast majority of kids do not report attempting suicide
Okay.
in the past 12 months. But with rises in youth suicide over the past 20 years and um, most experts not really having a great handle on what exactly is driving it and what exactly are the best solutions, finding evidence on anything that seems to
Right.
be moving the needle was really, really important, we thought. That's obviously an extreme end of the continuum of mental health problems. We wish that we had had other better measures of mental health
Right.
aside from suicidality, but that's all we had available to us. Um, so we found a few things that were, looked like good news, but
Hmm.
where I would characterize our evidence as being just not as strong. So we found some evidence of reduced suspensions from school after schools implemented this program, and we found some evidence of reductions in juvenile justice involvement after
Right.
schools uh, adopted this program. Where we what things that we didn't find though, we didn't find any effects of this program on attendance.
Mm.
We didn't find any effects of this program on standardized test scores, and we didn't find any effects of this program on substance use that is self-reported by the students. And which is maybe surprised me a little bit because those are some things where previous work that I've done and some
Yeah.
work that has been done by other economists has found some types of effects similar to that. We didn't find it. One thing that I think is also just important to know is we didn't find any evidence of this program making things worse.
Right. Oh, okay.
Where we found any evidence,
Okay.
it was of things improving after schools
Right.
implemented this program.
I mean, so first of all, on the attendance thing, what's interesting about that is while obviously attendance is a huge predictor of academic success, and from a lot of different studies, as you've mentioned, it's also been recognized that attendance is not something that the student controls entirely. And so in other studies that we're trying to, that in the past that have tried to predict attendance, there's a tremendous, there are a lot of household variables that end up predicting attendance. So just addressing, Ezra, it's one of my soapboxes in this show is that we always talk about youth sometimes out of their environment, like they are alone in this world, right? But when we start to look at their socioeconomic world, we recognize that there's all these things that, we can't expect a child, for example, to outregulate his or her parents, right? We can't expect them to have, a more organized life than exists at their home. So when I hear that attendance one, which I think you were right to think, boy, this could really help with that. I also recognize that in the socioeconomic model, there's all these things that are controlling that attendance. So that's interesting.
Yeah, well, so I agree with all of that. And the other thing that I would add is the fact of the matter is that attendance rates are actually pretty high to begin with.
Yeah.
So if we're looking for something that is ostensibly maybe improving attendance, there's not that much room. It's already
Right.
pretty close to the ceiling, at least in the school districts that we were studying. So it's not to say it was perfect, but it just gets harder to try to move the needle on some of that.
Well, and then I'm very excited, even though these were, as you described, as modest effects on things like out of school suspension and criminal justice involvement, because it's now come up on multiple episodes here, research that shows that, that out of school suspension as well as a criminal justice involvement that predicts really undesirable stuff for the child for the rest of their life. And we've had researchers on talking about how, for example, out of school suspension predicts civic engagement on the long term. So kids that experience out of school suspension are less likely to vote, less likely to participate in their communities. They just kind of end up looking at the system as not as stacked against them and nothing they want a part of in a weird sort of way, right? Which you can see. So both of those things I found really interesting. But boy, that suicidality, or it was suicidal behaviors, right? So this is attempted
Right.
suicides, right?
It's self-reported attempted suicides in the
Right.
past 12 months. So I can tell you that. So we also had a similar survey question that we analyzed that was around suicidal ideation,
Hmm.
that wasn't suicide attempts. Um, and what we found there was directionally the
Hmm.
same, but it wasn't statistically significant.
Were you able to look at all about whether or not there were certain demographics that benefited more from these services?
Yes. So, and this was something that we tried to be very intentional about. And we had a lot of information on this, and part of what we really were trying to be attentive to was, does this model improve health equity,
Right.
particularly along the dimension of racial and ethnic health equity? And does this
Mm-hmm.
affect what we know are existing longstanding disparities and inequities in access to mental health services and use of mental health services? Um, and the story here is maybe somewhat. It's not totally straightforward.
Mm.
So we found some evidence that when we look at outcomes related to actual mental health services use, we saw some evidence that students from racial and ethnic minority groups had greater increases in use of mental health services than students who were non-Hispanic white students,
Mm.
um, suggesting that this program is maybe doing something to narrow some of those inequities. However, for all of the other outcomes that we looked at, things related to suicidality, academic performance,
Interesting.
substance use, all the other things, we really didn't find any sort of clear pattern that was looking across racial ethnic groups, but also, we looked by socioeconomic status based off of whether students were eligible for free or reduced price
Mm.
lunches. We looked even by some things that we thought would be really clearly an indicator of high risk for mental health problems, like any involvement with the child welfare system. We did this very complicated machine learning analysis to identify what kids that we thought looked like high risk of mental health problems. We didn't find much of any consistent patterns
Hmm.
there for who benefited the most from this program.
I know that the data might not be available for this, but I'm also thinking about how some of the big mental health issues, even though we know that they start much like earlier, as you pointed out, than when they fully manifest. We see some of the most dangerous behaviors, like when like 19 through 23, right, is we're starting to see like real spikes, and especially in completed suicides. That's when we're seeing that happen. Is there any opportunity, do you think, for you to follow through and with these students and get later uh, data on their later life?
Um, it's possible, but
Right.
it becomes very
Yeah.
challenging,
Yeah.
unfortunately. In theory, there's some sorts of information that the state of Minnesota might
Might have.
allow
Right.
us to link in the future, but for very good reasons. It's, related to people's privacy.
Right.
Uh, Governmental entities are typically not that excited to let researchers like me have total access to this
No,
sort of
I
information.
can only
So,
imagine the
yeah.
paperwork you had to file to get the data that you got. Like that, it was giving me a headache just thinking about all the different entities that you had to get
Yeah.
permission from.
Yeah, and also, to be clear and to put
Hmm.
anybody's, any parent or teacher's mind at ease who's listening to this,
Right.
like, we never knew names of anybody.
Right.
Everything was entirely de-identified and went through institutional review board approval before we received it. We do not personally link anything. There was a center at the University of Minnesota that does that. That is entirely above board. But yes, that center, it was a very big lift to put everything together.
I know that we hadn't planned on talking about that, but thank you for mentioning that because I know that there are different states, and a lot of my listeners are in Arizona, for example, and there's a state law in Arizona that's basically making it impossible to conduct some of the research that you're doing now, and the fight against it, the fight for this bill that eliminated school-based studies like this was led by parents that were afraid that like researchers like us were spying on their parents and judging
Mm.
them based on the questions that we were asking of the students. So thank you for sharing like kind of the safety measures that are in place. Those measures were in place in Arizona too, but people just don't seem to understand them or give them enough lip service. So thank you. Were you? I know you're an economist, and I know that means you don't like to get inside the black box. That you want to. Were you able though? Did you form any ideas about what could be done with this program to even improve the outcomes?
Yeah. Yeah, if I had more time and available effort and also a broader skill set, I really would have loved to have dug more into the sort of just the implementation
Mm-hmm.
details of this. So one thing that we were able to get some insight into was in each of these schools, not in some of the schools that this was implemented, like how much FTE, like full-time effort clinicians were actually available,
Right.
and it did vary somewhat. I think the average was about one FTE per school for the most typical schools, but that did vary, and unfortunately, we didn't have enough information available from enough schools in detail about that we could try to look and see like, well, maybe the schools that had more FTE per capita in the school had better outcomes. We just weren't able to do that analysis. Um, but I think it sort of stands to reason that's one dimension
Mm-hmm.
here, that where the details implementation, if you are dedicating more resources to this, you sensibly might expect to have better outcomes as a result. Um, Aside from that, I don't really have any great insight, but I think that you could think about what are some of those features that might be important and that could relate to, what is the experience and the training
Mm-hmm.
of the clinicians that
Mm-hmm.
are in the school? What is the how effective is the relationship between the mental health providers or clinicians and the actual school
And
district? Because
and
again,
the
in this
school,
model school-based
yeah,
mental health services, the clinicians are not school employees. They are
right,
working for independent mental health services agencies where the agency enters into an agreement with the school
right,
district to just co-locate clinicians in that school during when school is actually happening.
yeah,
Um, and if there's a really good relationship between the mental health services organization and the school, I
mm-hmm.
think that you would expect this to work much better than if it's not a great relationship. Um, I think that matters. The degree to which the clinicians, part of this model is not just the direct service delivery. That's a major part of it, but another part of it involves training school staff.
Mm-hmm.
That includes teachers, but it also includes administrators and it includes student support staff as well. And so training in identifying mental health problems and referring to the school-based services when needed. And I think that that's probably done with varying degrees of success.
Right.
And where that's more successful, I think you would expect to see overall outcomes of this program to be more successful.
In that way, I think it parallels the use of school resource officers. Because initially, when schools started adopting school resource officers, the data were pretty negative that school resource officers made schools less safe, right?
Mm,
And when people started to analyze that further, they found out that it had a lot to do with how the schools were using the school resource officers. And there were a lot of schools that were waiting for problems to rise to the level that the school resource officer could intervene. And I know from my own experience as a school mental health counselor early in my career that there were a lot of people that were sent to counseling because the teacher didn't want to deal with them anymore. They were a behavior problem in the class, and then they kind of waited for a reason to suggest that it was a mental health issue. So
mm,
what we were seeing in our caseload were not kind of diagnosable mental health problems, but kids that didn't get along with their teachers in that particular learning style in that particular class, right? So they
hmm
only had a mental health problem when they were in math, for example, right? So I
Yeah,
think that your points about the orientation and the training of the school and not just of the counselors, I think, is really important.
yeah, yeah, yeah. One other thing that I just remembered is I think an important factor here that is again nothing that we were able to look at, but I think is probably very very important for the success of these programs is uh, to what degree do the clinicians that are working in these programs look like the students that they are
Mm,
actually serving?
right.
And if not, are they equipped and trained to deliver culturally appropriate and sensitive
Right.
services? Because if they're not, we shouldn't expect that they're going to be super successful. And I think that there are many reasons I think that that's
Oh,
incredibly
yeah.
important.
And again, for my listeners, this is something that's come up when we've talked about child protective services and who the
Mm.
officers are who are going and investigating families, and whether or not they understand the culture and the community that they're going in to help. So this has come up before, and we've known from a study done in Florida that when you change the cultural competency of CPS workers, that you change the outcomes of the number of kids who
Oh,
have
that's really
out of home
interesting.
placements. Yeah, so
Hmm.
so this stands to reason. So you see, listeners, it's all circular. This is one set of issues playing out in different locations that affect our kids. Ezra, I just want to thank you so much for this research. I want to thank you for turning your economist brain on this problem that's affecting all of our kids. I really appreciate it, and thank you so much for being a guest on Talking About Kids.
Thank you. It's my pleasure. And I want to actually make sure that I fully acknowledge my co-authors on this work.
Yes.
This is very much a team effort. And so this is work that I did together with Irina Zainulina, who is a PhD student at the University of Minnesota in the Applied Economics Department, and Mark Sander, who I mentioned previously. He works for Minneapolis Public Schools and Hennepin County and does that direct school mental health work, and then Aaron Sojourner, who is also an economist and was previously at the University of Minnesota and is now at the Upjohn Institute, which is a labor and education economics think tank in Michigan. So it was a wonderful team effort to put this all together.
That was Ezra Golberstein. More information about Ezra, including a link to the article we discussed, is at talkingaboutkids.com. And when you do visit talkingaboutkids.com, please let me know what you think about the podcast. I look forward to your feedback. The Talking About Kids theme song is by the Senators. For more of their music, go to thesenatorsmusic.com. And remember, kids are young goats and young humans. And the difference is that young goats are easier to manage